everyone, and welcome to this episode of The Forefront. Stroke and diabetes don't lose a moment. My name is Jody Lavin Tompkins, and I'm a nurse and certified diabetes care and education specialist and director of accreditation and content development at the Association of Diabetes Care and Education Specialists. Joining me today is Debbie Hinnen, an advanced practice nurse and certified diabetes care and education specialist at the University of Colorado Health in Colorado Springs. I'm excited to be speaking with Debbie today about stroke and diabetes because she works with many people who are at an elevated risk for stroke. We'll discuss the importance of awareness of symptoms and of taking urgent action so that available treatments can be used to reduce long-term disability. Welcome, Debbie.
Thank you. I am glad to be here with you today to help raise the awareness of stroke.
Awesome. Well, let's dive in and let's talk about why this topic is so important for our audience.
That is such a great question to lead with. Only about 10 to 20% of people who have a stroke get to the hospital in time to get the TPA clot busting drug. And if they don't get that treatment, they may have increased risk for long-term, serious, lifetime disability, like learning to walk and talk again. And of course, they may end up in long-term care. Stroke occurs every 40 seconds, and someone dies of a stroke every 3.5 minutes. I mean, Jody, more people die of stroke every year than die of diabetes. So we have to impact prevention and awareness.
That's a really important point. And I'm sure our audience, you said that more people die of stroke every year than diabetes. So let's dive into that and look at what the prevalence of stroke is in people with diabetes.
Our patients are at huge risk. 34, excuse me. Our diabetes patients are at huge risk. 30 to 40% of people hospitalized for stroke have diabetes. Diabetes increases ischemic stroke incidence at all ages, but it's most prominent in both Black and white individuals younger than 65. That's a surprise to me. People with diabetes are 1.5 to 4 times more likely to have a stroke. The risk for ischemic stroke increases by about 3% per year of diabetes, and it triples after 10 years. The association between diabetes and stroke risk differs between the sexes. Compared with males with diabetes, females with diabetes have a 27% greater risk for stroke when baseline differences in other major cardiovascular risk factors were taken into account. And that includes all-cause mortality, all-cause hospital readmission, and composite of mortality and cardiovascular readmission and ischemic stroke TIA readmission. In fact, in the Greater Wisconsin Stroke Registry, diabetes was associated with a higher risk of adverse outcomes over 3 years after stroke. Don't you find that just frightening?
Yes, those are some very scary statistics. And so we should really look next at the risk factors that increase the risk of stroke for a person with diabetes.
Well, the manageable risk factors are essentially what we're coaching our people with diabetes to manage. Manage their diabetes, manage their hypertension, lipids, stop smoking, poor circulation, increase physical activity, work on obesity, but also AFib. People with diabetes who've had an ischemic stroke, which of course is most common, are more likely to have high blood pressure, myocardial infarction, and high cholesterol. And these are risk factors we're already working on for primary and secondary prevention.
So you mentioned an ischemic stroke, and I know there's two types of stroke. Could you give us a brief overview of those two types and how they're treated?
Yes, of course. The two types of stroke are ischemic, which accounts for the vast majority, about 87% of strokes, and hemorrhagic. at about 13%. Ischemic stroke occurs when the blood flow to an artery in the brain is blocked. Hemorrhagic occurs when an artery is ruptured, causing swelling, pressure, and damage to the brain. Now, both of these may present with an acute neurologic deficit and high blood pressure, and urgent, timely treatment is essential for both. A CT scan should be done to confirm which type of stroke the person has had. And if it's hemorrhagic, a clot-busting lytic would not be given, of course. But if it's ischemic, the thrombolytic agent is critical and should be given within 4.5 hours of onset of symptoms. There are TPA drugs available that are given via IV drip and now IV bolus. The webinar that Dr. Taub is going to do will get into a lot more detail around this. But if the clot busting drug, the TPA, is given within 4.5 hours of the onset of symptoms, patients' chance of walking out of the hospital without long-term sequelae are greatly improved. If the thrombolytic agents are not successful or the patient comes in after the 4.5 window, the, if the thrombolytic agents are not successful or the patient comes in after the 4.5 hour window, they may do a thrombectomy to remove the clot if the center has that capability.
Okay, so that's an if, and that means that some centers do and some centers don't. So I understand that there are stroke centers that can provide more comprehensive care. And I think our audience would like to know more about them and the importance of maybe knowing where those are.
So I think the most critical thing for our educators and providers to know is that we should use EMS, not family transport, to get to the hospital as soon as possible. EMS, of course, will do that early screening and call ahead, but they will know where to take people. So we're looking at primary stroke centers and comprehensive stroke centers. So primary stroke centers can indeed give the IV thrombolytic and manage the medical management of that. The comprehensive center, though, has that capability for endovascular therapy. The stroke unit in primary is designated for strokes and acute care, but in the comprehensive stroke center, they have 24/7 capabilities. That neuro interventionist is there 24/7. Neurologists are available. Now, guidelines, of course, are followed by both primary and comprehensive stroke centers, and there are different guidelines that each of those would follow. The neurological services are available for primary usually within 2 hours or 24/7. But in the comprehensive, 24/7 is available. The neurointerventionist is available. The neurologist is there and the neurovascular surgeon. So EMS accesses protocols. They follow that. They, in a comprehensive center, also begin to work on routing plans and recording a lot of the details for transport. But I must say, Jody, even if your hospital is rural, and a lot of us have been in rural America for a lot of our career, telehealth now has increased. The telehealth consult to the stroke centers and the neurologist are increasingly available. And they'll coach the primary center or they'll coach the rural center on starting the IV and transporting. It's called drip and ship.
Oh, I like that. That's great. I could remember that. So, with all of this in mind, everything we've gone over, then what messaging should we be giving the people with diabetes we see about stroke?
Well, urgency is, I think, top of the message, but we need to be sure the person with diabetes and their family member know the symptoms. We have used the acronym of FAST, but now I have updated my patient teaching to include the newer acronym called BFAST. And B would stand for balance, E for eyes, there may be vision changes. F for face, as we're very used to seeing this classic drooping or arms and hands weakness for the A. S for speech, which may be slurring, and time, T. So time is, of course, urgent to call 911. So I think if we can update our teaching for patients and particularly family members to be fast, that's going to help people be more aware of some additional symptoms that we need to look for. Balance, eyes, face, arms, speech, and then, of course, time. But I must say, we want to encourage people to not be reluctant. If something seems off, that family member, that loved one should call 911 ASAP. It's okay to be wrong, but if you're right, time will make a huge difference. EMS can use lights and siren to get to the hospital. You can't. EMS will call ahead and they'll have the emergency department staff ready for you. You know, I think about Grey's Anatomy. You want your emergency staff waiting for you at the door. And if you drive your loved one to the hospital, you'll have to wait in line to be checked in. And those are valuable minutes lost. Remember, the clot busting drug has to be given within 4.5 hours of the start of symptoms. So again, it's okay to be wrong. But if you're right, calling 911, that time will make a huge difference in how your loved one lives the rest of their life.
So the BFAST acronym is really important for us to teach the people we work with, it sounds like, and calling 911, bottom line. And you gave some really good reasons for all of that, especially that short time frame that they need to get to the hospital for treatment. So can you review with our audience what you think our role is in helping to prevent stroke? Because obviously you said the sequelae could be really detrimental to someone's future life. So how can we help prevent stroke?
Our role is very important. And I think what we need to really shine a light on is that cardiovascular disease includes stroke. We talk about MI, we talk about heart attack, but stroke is part of cardiovascular disease. And as diabetes care and education specialists and prescribers, we need to follow the treatment guidelines. And I love that all of the guidelines are essentially in lockstep. ADA and EASD 2022, ACE 2022, DCRM, the Cardiovascular Renal Metabolic Group, has 2021 guidelines. American Heart and American Stroke have 2021 guidelines, and they're essentially the same. Um, and the guidelines are essentially the same. Beyond lifestyle, which of course we're looking at low sodium and Mediterranean diet for people with diabetes and prediabetes, we need to write or influence the prescription for long-acting GLP receptor agonist or SGLT2 inhibitors for people with diabetes at risk of cardiovascular disease, regardless of A1C or other glucose lowering meds. I am so pleased to see the guidelines be so proactive and so quick to match the cutting edge research. So again, our role would be early on to help influence that GLP, SGLT2 initiation, regardless of whether there's existing cardiovascular disease, if people are at risk, and regardless of what their A1C is. Now, in addition to that, we know pioglitazone may be helpful if they've had a previous stroke, and certainly a statin at the highest tolerated dose, maybe omega 3s if the triglycerides are over 135. Hypertension management, of course, is huge. The goal, we want less than 130/80. And when we think about antithrombotic, antiplatelet, and anticoag, primary prevention is an aspirin. And secondary would be some of the Plavix, Brilinta, some of those drugs that are newer. But bottom line, as you say, is to make sure that our patients are aware of stroke symptoms and they know the urgency of calling 911.
Well, Debbie, thank you so much for taking the time to join us for this episode of The Forefront and sharing your knowledge and experience with our audience. For me, as a diabetes care and education specialist, I know how useful this information is for practice. So I'm sure our listeners really appreciate hearing your firsthand experience.
Thank you, Jody. And again, I think you're exactly right. We have to raise the awareness, focus on BFAST, and call that 911 for quick transport that connects all of the links in treatment. We have to have that all done within 4.5 hours of the onset of symptoms. Thank you, Jody.
Well, thank you again, Debbie. And we wish to also thank our sponsor, Genentech, once more for their generous support of this episode of The Forefront. The information presented here is for informational purposes only and may not be appropriate or applicable for your individual circumstances. This podcast does not provide medical or professional advice and is not a substitute for consultation with a healthcare professional. Please consult your healthcare professional for any medical questions. Thank you for watching, and please join us again for future episodes.